Critical care, ICU care. Indications for mechanical ventilation. There are a list of indications, but I'll tell you the very common one that you should know. On the basis of ABG and on the basis of the, you can say, lung functions. PO2 less than 50 mmHg. But these are not the hard and fast, just many factors we continue, even clinical scenario of the patient also we see to take a decision. So PO2 less than 50 and PCO2 more than 50. PO2 less than 50, PCO2 more than 50. And then usually PF ratio. PF means PO2 plus FiO2 ratio less than 300. Less than 300. Normal is more than 400, you know. On the basis of lung function, if patient is becoming very tachypneic, means respiratory rate is more than 35 breaths per minute. Then if patient is not able to generate tidal volume of at least 5 ml per kg or vital capacity of at least 15 ml per kg, and if the dead space volume is more than 60%, so this is also indication to take a patient on ventilator. So these are the common indications you can say to take a patient on ventilator. Ventilators are of two types: volume control and second is pressure control. Many classifications, but this is the basic one that you should know. Volume control means, as the name suggests, tidal volume will be guaranteedly delivered. For example, say you have set a volume of 500 ml and a respiratory rate of say 10 breaths. So what the ventilator will do, every 6 seconds it will keep on delivering that 500 ml. So that 500 will be guaranteed delivered, means volume is a controlled factor. So volume controlled factor means no risk of hypoventilation. So that's a major advantage. Volume is fixed means risk of hypoventilation will not be there. Pressure control, say you set a pressure, say I set a pressure of 20. So ventilator will deliver its breath till the pressure of 20 is achieved. After that, it will stop giving the breath. Now say if the patient develops bronchospasm, so this pressure will be achieved very early. So ventilator will deliver less tidal volume. So here tidal volume is not fixed, volume is varying. Volume varying means there is always risk of hypoventilation. So but now the disadvantage was that's a major advantage of volume control, and that's a major disadvantage of pressure control, that there is risk of hypoventilation. But the disadvantage of volume controlled ventilation is, say patient develop bronchospasm or lung compliance is reduced. If you give same volume to decrease lung compliance, that will increase risk of barotrauma. While that's a main advantage of pressure control, means pressure is fixed, means barotrauma will not be there, so decrease risk of barotrauma. But usually hypoventilation is preferred, uh, barotrauma is preferred complication over hypoventilation. So normally majority of the time we prefer volume controlled ventilation. So obviously pressure controlled ventilation will be preferred when uh, we can't accept barotrauma. Modes of ventilation. The most basic mode is control mode, that is CMV. Control mode ventilation, as the name suggests, means all breaths will be delivered by ventilator. Control mode. Total breathing is controlled by the ventilator. So in control mode ventilation, all breaths will be delivered by ventilator. Now the problem of ventilatory breath is that ventilator always deliver positive breath. So what will happen to intrathoracic pressure will be positive. So what will happen to venous return? Less. So less venous return means less cardiac output. So that can cause significant hypotension. Then assist control. So as the name suggests, means here ventilator can assist patient spontaneous breath as well as ventilator can deliver its own breath. So in assist control, say this is a patient spontaneous breath, but it is very low volume. So this will be assisted by the ventilator to a desired tidal volume, and ventilator can also deliver the control breath if required. Like say if patient respiratory rate is 5 and you have set a ventilatory rate of 10 breath with ventilator. So what the ventilator will do? It will assist those 5 breaths and remaining 5 breaths it will deliver in control mode. Then synchronized intermittent mandatory ventilation, SIMV. So as the name suggests, look at this word mandatory, means whatever the rate you have set, that will be read as mandatory by the ventilator. So say if you have set a respiratory of 10 breath with ventilator, so what the ventilator will do, it will deliver those 10 breath, but those 10 breaths will be synchronized with the patient spontaneous breath. Means either it will deliver between patient spontaneous breath, and if that is not possible, means ventilator is not finding enough time, then it will deliver its breath during inspiration. Means it will never deliver at the time of expiration. Otherwise what will happen, if the patient is expiring and ventilator deliver, there can be significant dysynchrony, and that can cause even barotrauma. So these are the usual common modes. Then just one or two add-on modes I'll tell you, which are often used. And the most common add-on mode is positive and expiratory pressure, PEEP. So as the name suggests, means we are giving positive pressure at the end of expiration. Otherwise, what happens during expiration? Alveoli collapses. So gas exchange cannot take place during expiration. But if you keep alveoli open even during expiration, gas exchange will take place even during expiration. So obviously this PEEP is required for the situations where there is a problem in gas exchange, that is ARDS or say pulmonary edema. So particularly these patients, ARDS, pulmonary edema patients will require PEEP. So that's a positive pressure will keep the alveoli open even during expiration. Then CPAP, continuous positive airway pressure. Actually, it is a misnomer. It's not continuous positive airway pressure. This is just the PEEP given to a non-intubated patient. So it's just a PEEP given to a non-intubated patient, or you can say non-invasive method of giving PEEP. Non-invasive means it will be given through mask. And you must have seen a tight fitting mask is there which is tightly fitted and it deliver positive pressure during expiration. So I told you it's actually a misnomer. Then we have now you can say dual modes. Dual modes means which combine the benefit of pressure as well as volume. And there are two modes which are more commonly used, that is bi-level volume guaranteed, or more commonly nowadays called as the pressure regulated volume controlled. Means same, pressure regulated volume controlled, PRVC. So means you set the two levels of pressure. Say I set a lower level of pressure of 5 and the upper level of pressure 20. So means airway pressure will never fall below 5, means gas exchange will take place even during expiration. Upper pressure 20 means at the time of delivery of the tidal volume, airway pressure will not go above 20, means that will prevent the barotrauma. And in between these two pressures, whatever the volume I have set will be guaranteedly delivered. Volume guaranteed, volume controlled. So pressure you have regulated both lower and upper, and volume you have controlled. Volume is guaranteed. So avoiding the risk of hypo, avoiding the risk of hypo. So this you can say, nowadays you can say they are the best modes. So if they ask you the best mode, so these dual modes are the best modes because they combine the benefit of pressure as well as volume. So modes of ventilation we have discussed. Now non-invasive ventilation. Non-invasive ventilation means ventilation given through mask. And actually now we should not be in hurry to intubate the patient. First, see, if it is severe hypoxemia or patient is in respiratory arrest, obviously we'll be immediately intubating. But mild to moderate hypoxia, you should not immediately jump to intubation. You should reasonably give a trial with non-invasive ventilation, and we have seen a significant number of the patients, they get benefited by non-invasive ventilation. So non-invasive ventilation means it will be given through a tight fitting mask, and obviously it can be only used for mild to moderate hypoxia. And important thing is there should not be any risk of aspiration. Should not be any risk of aspiration because mask ventilation will increase the risk of aspiration. And obviously another disadvantage of this is patient can have claustrophobia. Continuous tight fitting mask giving high pressures, that can make patient very claustrophobic. And considering this claustrophobia and patient comfort, now we have new method of giving non-invasive ventilation, that is high flow nasal cannula. So as the name suggests, high flow nasal oxygen or high flow nasal cannula, HMFC or HFNO, nasal oxygen. So here it delivers very high flow, means 60 to 100 liters per minute, but through a special nasal prong. So this high flow creates a kind of positive pressure in the airways. So we are just generating this positive pressure through this flow. So patient comfort level is very good. So this is important, and many COVID patients actually we have seen. I've seen many of these COVID patients or even ARDS patients, they who are not tolerating this mask ventilation, they respond very well to this high flow nasal oxygen, and we can avoid the need for intubation. So definitely there is a very high chance to have question on high flow nasal oxygen because it actually has prevented many, you can say, intubations. But very important is that gases should be humidified. If you are giving so high gases, they should be humidified. Now, normal initial settings for a ventilator, if you are putting a patient on ventilator, Now, a very, very important thing is tidal volume should be low. The concept of low tidal volume, very important. I told the question can be asked, and you know that in AIIMS the question came that tidal volume should be less. So this obviously is to prevent barotrauma, not the normal tidal volume of 10 to 12. It is 4 to 6 ml per kg. And obviously to begin FiO2, obviously delivered oxygen will be 100% one, but as soon as possible try to get it to less than 50% because oxygen toxicity is an issue. And very important thing is try to keep your uh, plateau pressure to less than 30 centimeter of water, and this is called as lung protective strategy. So all ARDS patients, including COVID patients, we have to go for lung protective strategy. Tidal volume 4 to 6 ml per kg, FiO2 to begin with 1, but as soon as possible go for less than 0.5, and plateau pressure should be less than 30, and flow should be high, usually 60 to somewhere 120 liters, because their requirement may be high, so they may require high peak inspiratory flow to deliver the same tidal volume. So flow somewhere from 60 to 120 liters per minute. So CPCR, cardiopulmonary and cerebral resuscitation. CPR nowadays you know is called as CPCR, cardiopulmonary and cerebral resuscitation. Now CPR is obviously done for cardiac arrest, and uh, what is the definition of cardiac arrest? Inability of the heart to generate the cardiac output is simply called as cardiac arrest. So normally we actually misinterpret it. We normally coincide cardiac arrest with asystole, but that's not true. Actually, we see three rhythms during cardiac arrest: ventricular fibrillation, asystole, and pulseless electrical activity, that is PEA. So in asystole there is no cardiac activity, but here you can see ventricular fibrillation and pulseless electrical activity. There is electrical activities in the heart, but that is not able to generate a pulse. Okay. Now you know that the conventional teaching had been, or conventional our policy had been ABC: first airway, then breathing, and then circulation. But in 2010 they changed the sequence to CAB, chest compressions, and then airway, and then breathing. So this chest compressions means you have to give around 30 compressions over a period of 18 to 20 seconds. And what you are doing by giving these 30 compressions, studies have proven that there is significant oxygen which is present in dissolved form in blood. So by giving 30 compressions over a period of 20 seconds, you are just pushing that oxygen to brain and heart, and by the time your airway equipments also become ready, and then you can manage airway or breathing. So now the sequence has been changed from ABC to CAB: compression, airway, and then breathing. You know that CPR can be done under three heads: basic life support, advanced cardiac life support, and post cardiac arrest care. Now, what is the difference between basic life support and advanced cardiac life support? In basic life support, airway is managed by manual methods, while advanced cardiac life support, airway is managed with the help of equipments. Breathing by mouth to mouth Although mouth to mouth is now only for the trained rescuers, not for a common man, or bag and mask is a part of basic life support. Anything beyond bag and mask, that can be your endotracheal tube, that can be your laryngeal mask airway, or that can be by tracheostomy tube, they are the part of advanced cardiac life support. Circulation in both BLS as well as ALS is managed by cardiac massage. Defibrillation by automatic external defibrillators is a part of basic life support, while defibrillation by manual defibrillators is a part of advanced cardiac life support. Why it is so? Automatic external defibrillators, you would have seen that they can be used even by common man. You have to just simply switch them on, place the electrodes over the chest, automatically they will diagnose the rhythm, and if the rhythm is shockable, they will give shock. Now, since they can be used by common men, so they are the part of basic life support. And in fact, 2015, they changed their name from AED to PAD, that is public access defibrillators. Means they are for the public access. That in West you will see everywhere, airports, markets, malls, subways, you will see these public access defibrillators. Manual defibrillators, we have to use them, we have to diagnose the rhythm, we have to charge them, and we have to give shock. So manual defibrillators can be only used by medical personnel, so they are the part of advanced life support. Drugs obviously can be used by medical personnel, so they are the part of advanced cardiac life support. Now, cardiac massage. Cardiac massage, you know that during cardiac massage, what should be the compression area? It should be lower one third of sternum. I've seen people doing this mistake, that they do cardiac massage over precordium. So that can cause significant injury, and ineffective cardiac massage should be lower third of sternum. Children and infants little high, almost you can say junction of lower and middle sternum. Not exactly mid sternum, but junction of lower and middle sternum. Pulse check for adults is carotid. For infants, brachial. And for children, it can be brachial or carotid. Anyone you can use. Compression in adults is done with two hands. With one hand locked over the other, and the pressure should be generated through shoulders. Means your hand should always be straight. There should not be flexion at elbow. For children, one hand may be sufficient, and for infants, just 2 to 3 fingers may be sufficient due to the compression. Compression rate now for all ages is 100, but it should not exceed more than 120. So 2015 guidelines, they say that compression rate should not exceed more than 120. So you can say 100 to 120 for all ages. Depth, mandatory 2 inch in adults, 1.5 inch in children, and 1 inch in infants. So it has been changed. Previously, there used to be range, but now they have removed this range. Mandatory 2 inch, but 2015 they say that depth should not be more than 2.4 inch. Means important is there, but not too deep. Now, ratio of compression to breathing. Now, ratio of compression to breathing depends whether you are doing CPR with advanced airway or without advanced airway. Without advanced airway means you are ventilating with bag and mask. With advanced airway means you have already intubated the patient. So, without advanced airway, if you are a single rescuer, then ratio should be 30:2 for all ages. 32:2 means what you will do, you will give 30 compressions, go to mouth, give 2 successive breath, come to chest, give 30 compressions, come to mouth, give 2 successive breath. But if you are 2 rescuers, then this ratio for infants and children will change to 15:2, but for adults it will still remain is going to remain 30:2. So ratio of compression to ventilation for adults is always 30:2 irrespective of the rescuers. But once you have intubated the patient, then all these ratios finishes. Then one person will continue compression at a rate of 100 to 120 compressions per minute, and second person will give 10 breaths per minute. For all ages it is same, means one person will continue compression and second person by watch will give one breath after 6 seconds, and the person giving compression will not stop at the time of breath, means there is no synchronization. Previous method there used to be synchronization of 5:1. One person will 5 compression and then he'll stop, and then the second person will give one breath. So now it should be no synchronization. One person continue compression at a rate of 100 to 120, and second person by watch will give one breath after every 6 seconds, and the person giving compression will not stop at the time of breath. Now CPR, very important component of CPR is arrhythmia management. Arrhythmia management, and uh, if you are doing even 100% successful CPR, you are just generating around, you can say, one third of the cardiac output, and one third of the cardiac output obviously will not be able to sustain life for long. So you have to reverse the rhythm. So arrhythmia management can be shockable rhythm and non-shockable rhythm. And shockable rhythm includes your ventricular fibrillation, pulseless ventricular tachycardia, and polymorphic ventricular tachycardia, which is also called as torsade pointis. So these are the shockable rhythms. Now, as per new guidelines, all shocks will be of 360 joules, not previous 200, 300, 360 joules if you are using monophasic, or 150 to 200 if you are using biphasic, because biphasic they deliver current from two directions, so the net current will be same. Then another important thing is, our previous method of CPR used to be that we used to give shock. After giving shock, we used to look at the monitor, and if the rhythm is shockable, or if the rhythm is sinus, we used to stop. But now they say after cardiac arrest, it take around 2 minutes for the heart to generate the cardiac output. So these 2 minutes should be considered as period of cardiac arrest, and you have to give CPR. So after giving shock, we will not check the rhythm. We will continue CPR for 2 minutes before checking the rhythm. And only if the rhythm is an organized rhythm, then only we will check the pulse. And only if the pulse is palpable, then we will stop the CPR. So the end point to stop CPR is a return of spontaneous circulation, short form as ROSC. So in exam also you will get this as ROSC, return of spontaneous circulation. So now the end point to stop CPR is return of spontaneous circulation assessed by palpating the carotids. So shockable rhythm sequences. You have started CPR, and once the defibrillator arrives, you will defibrillate. You will defibrillate, and after all shocks, I told you 360 joules. After defibrillation, we will continue CPR for 2 minutes, and then only we'll check the rhythm, and only if the rhythm is organized, then you will check pulse, check carotid, and only if carotid is palpable, then you will stop CPR. Okay. Then say if the rhythm is still shockable. If the rhythm is still shockable, then your next step would be inject adrenaline and give shock. And now again continue CPR for 2 minutes and then check rhythm. If the rhythm is say shockable, still shockable, the next step would be to again repeat the second dose of adrenaline. Actually before 2015 at this point we were using vasopressin, but that has been removed. So second dose of adrenaline plus shock, and again continue CPR for 2 minutes. Still check the rhythm, says the rhythm is still shockable, then your next step would be inject amiodarone. If amiodarone not available, then lignocaine and magnesium sulfate for polymorphic VT, amiodarone plus shock, and again continue CPR for 2 minutes. If the rhythm is say still shockable, then go to step number 2. Step number 2 means adrenaline plus shock, and continue the same sequence. If there is no response for 20 minutes, then you can declare the patient. So this 20 minutes is very important. Non-shockable rhythms, I told you, are asystole and pulseless electrical activity. Actually, this pulseless electrical activity, as the name suggests, any electrical activity other than ventricular fibrillation, ventricular tachycardia, which is not able to generate pulse, is classified as pulseless electrical activity. And any emergency that we encounter, hypotension, hypovolemia, tension pneumothorax, acidosis, electrolyte imbalance, cardiac tamponade, anything can cause this pulseless electrical activity. So management for non-shockable rhythms is nothing, just continue CPR and keep on repeating adrenaline after every 2 to 3 minutes. And again, no response for 20 minutes, you can declare the patient. Other than continuing CPR, important is to search for causes. In fact, American Heart Association has given 5H and 5T so that you can search the causes for pulseless electrical activity: hypovolemia, hypoxia, acidosis, like that, tension pneumothorax, tamponade. So there is a sequence. So one team should be searching for the causes and second team should be doing CPR. Because if it is a tension pneumothorax, just by putting a needle in a second intercostal space could have relieved the uh, pulseless electrical activity. So searching for causes is as important as doing CPR. Then nowadays you can say the only drug that is used for CPR is adrenaline, and it can be given through three routes: intravenous, intraosseous, and endotracheal. Intracardiac is absolutely contraindicated. Absolutely contraindicated. It is no more effective than any of these three routes. and it can cause significant myocardial damage. And concentration of CPR for all these three routes is 1 in 10,000. And now another very important change they made. Now intraosseous route is recommended for all ages. All ages means previously it was only given for children less than 6 years, but now it can be used for all ages and anything can be given. Anything means you can even give uh, transfusion through this intraosseous route. So what actually should be the sequence when you encounter an unconscious patient? So if you encounter an unconscious patient, say adult patient, if you encounter an unconscious adult patient, so first is scene safety. Very important. If not that is building is falling and you start doing CPR, scene safety. After that, now assess responsiveness, because and how you assess responsiveness? By shaking and shouting. So maybe just person may be sleeping, you don't start CPR straight away directly. So assess responsiveness by shape. Then if the person is unresponsive, if the person is unresponsive, then they say if you have mobile app which is there in West, just by pressing that app you can call for emergency response team, but that is not there in India. uh, if that is not there, then what you have to do, you have to assess breathing and circulation simultaneously. How you assess breathing? Just by scanning for chest movements, and circulation obviously by palpating the carotids. If they are absent, pulseless, breathless, or even gasping, then before doing anything, just call for help. Means activate emergency response team. Why? For two reasons. One, you alone cannot do CPR, you need help, you need more people. And secondly, the cause of cardiac arrest in an adult patient should be considered VF until proved otherwise. This has been again debatable. uh, the cause of cardiac arrest is still ventricular fibrillation in adults, but it has been seen that the most common rhythm with which the patient present in emergency or when the paramedics they reach the home, they found it to be asystole, because by that time they reach or by the time the patient reaches the hospital, majority of this VF has been converted into asystole. So that is the most common rhythm that is presenting, but still the most common cause of cardiac arrest is VF in adults. So call for emergency response team, and in hospital setup we have code blue. So you have to immediately activate code blue without even touching the patient. After activating code blue or activating emergency response team, now you come to patient and start CPR. Uh, Start CPR. Okay, starting with cardiac, starting with C, A, and then B, and then defibrillate as early as possible. As soon as defibrillator arrives, defibrillate. But if it is a child, there is a difference. Now in child, after assessing breathing and circulation, here after assessing breathing and circulation, now start CPR and give 5 cycles, and then only call for help, activate emergency response team. Why? Because the cause of cardiac arrest in a child is asystole, and the management of asystole is CPR, which you have already started. So you are not in hurry to get the defibrillator. So that's the difference. So I think that should be all about. Later also, if any doubt, you can either mail me your doubt at dryadavaji@rediffmail.com, or at my Telegram group, Anesthesia Queries, and of course at our app, that is eGurukul. You can always send your queries and we will try to respond as promptly as possible. Okay then, any queries, most welcome, and thank you very much for attending the session.